Good day, everyone. My name is Hélène Hiwat. I am the coordinator of the National Malaria Program in Suriname. And I will be presenting to you a project that's been supported by the TDR over the past year. I'm in Suriname, where it's just the start of the day, and I'm very happy to be here with you. I would like to thank the TDR for giving me this opportunity. I'll start sharing my screen. And I hope it's visible.
Good. All good.
Thank you. So malaria elimination in Suriname, the last mile. Suriname is, the Republic of Suriname is situated in the Amazonian, and it's north of Brazil, in between Guyana and French Guyana. The population is very small. It's less than 600,000 people. And the coastal area of the country is malaria-free, but malaria is still an issue in the interior of the country, where we have different populations. We have a population of Maroons, which are descendants of African slaves living in tribal villages. We also have the original Amerindian populations living in tribal villages. And then there are the mobile, the moving migrant populations, who are remote gold mining sites, and those are mostly coming from Brazil, but also from some other countries as well. So the malaria epidemiology in Suriname changed a lot over the past years. It was the incidence was very high at the beginning of the century, and then we had a massive drop between 2005 and 2006. Which was especially related to the malaria in the villages. And then we realized in 2009 and 2010, and even before that, even though we had a large drop in indigenous cases, there was still the matter of import malaria cases, providing a risk to reintroduction of malaria in the country. And because of the mobile population, the gold mining population, there was still malaria happening in the mining sites. So what happened was that we have malaria transmission in the very remote illegal gold mining sites in the country. And these pose some challenge, especially when related to logistical costs, and also to the cost locally because of the gold-based economy in the mining sites. And then we have the challenge of the environment, which is not always safe for health workers. So there is a mobile migrant population largely coming from Brazil. There is a different language, different culture, and of course the context of gold mining is a specific context. The education level is generally low, and the people are often undocumented, which makes it even more of a challenge to provide services. And then there is a continuous cross-border movement from the miners in the Guyana Shield, so between the countries, especially French Guyana, Brazil, Guyana, and Venezuela. The miners are moving from productive sites between the countries to get the best outcome. So in Suriname, what did we do? There was, of course, a lot of study being done on how to adapt and target approach towards this new challenge of miners in the interior. And in this, we decided to also have a community-based approach, and a malaria service deliverer network was established. A malaria service deliverer is a person selected from the migrant mining communities and trained to provide malaria diagnosis and treatment to the people in the same mining sites or in nearby mining sites. The malaria service deliverer network provides very good benefits for the program in that it provides a targeted approach the people that are trained speak the same language, have the same culture, and live in the same context as the community that they are providing the services to. Also, because of the use of rapid diagnostic tests, we are better able to address the needs of this very mobile community. The mobility results in very little time being available to, for instance, wait for malaria results. So the rapid diagnostic tests are very helpful in that. And then the service delivery network also allows us to have real-time information from these remote mining sites and to get information about how many people are in a specific site, if new sites are established, and about the movement of the people. So because of this real-time information from the remote site, we can deliver a timely response. The risk of this approach at this moment is that it's very donor dependent because of the high costs. But in all, having the malaria service delivery network is actually saving funds because of less logistical costs if it was delivered at central level to the people. So to have the people in the area themselves is very profitable for the malaria program for that as well. So gold mining is a big issue in the Guyana Shield. There are several mining sites on the Suriname side of the border. What you see here is the border between Suriname and French Guyana. And the estimated population of mobile miners in Suriname is about 20,000 people, while the miners in French Guyana are about 11,000. So there is a continuous movement between Suriname and French Guyana because the French Guyana context differs from Suriname. In the French Guyana context, even though there is a very good healthcare system which provides access to everyone coming to the system, there is no healthcare in these illegal mining sites. And also the malaria service delivery concept that was very successful in Suriname is not allowed in the French legal framework. So it's not being implemented in the French Guyana mining sites. Due to this, the malaria in the mining sites in French Guyana continues to be transmitted, and there is a large undocumented malaria reservoir in these illegal mining sites. Here is a graph shown from a publication by Dr. Dubin from French Guyana that shows that in the mining sites in French Guyana, the prevalence of malaria is still very high. And the same is recognized in the epidemiology study from Lise Musset, which shows that even though the malaria cases are diagnosed in French Guyana in the health system, which is the solid blue line, the dotted line above the solid line shows that in neighboring countries, the malaria cases coming from the French Guyana mining sites far exceed the numbers that are recognized in the French Guyana formal health system. So this is just confirming that a lot of malaria is still going on in the French mining sites, and that cross-border transmission is happening toward the neighboring countries. So within a collaborative and innovative approach between the countries Suriname, Brazil, and French Guyana, a new intervention was developed called Malakit. And this Malakit is a self-testing and self-diagnosis kit for malaria that is provided to gold miners that are moving into the French mining sites. So those miners coming into Suriname or coming into Brazil were provided with these self-diagnosis and self-treatment kits when they were planning to go back to the French Guiana mining sites. The aims were to prevent emergent drug resistance in the malaria parasite because the absence of healthcare in the French mining sites has led to a lot of self-treatment with inadequate drugs. So to prevent the emerging drug resistance in malaria parasite, it's important to make sure that people have access to quality drugs and also to the testing, to diagnosis. The second aim was to reduce the malaria burden in the French mining sites and also to reduce cross-border transmission. The kit was provided along the borders between Suriname and French Guiana, and also between Brazil and French Guiana, to the miners that were traveling to the French mining sites. So more detail about the Malakit project can be found in the Malakit project website. It explains more about the interventions, shows the training and engagement tools that were used to provide the kit to these populations, and photos and videos of the interventions. And it also has some links to publications and reports that result from the pilot study. So the pilot study has now been completed, and Suriname has decided to elevate the Malakit to a national intervention. So in Suriname, the Malakit is continuously provided to the miners that are going into the French Guiana mining sites to allow them to have access to diagnosis and treatment. There is, however, a challenge again. The focus originally for this Malakit was to have treatment of interruption of Plasmodium falciparum transmission, which is a very important malaria species. But the challenge is that through the years and toward the elimination of malaria in the region, especially in Suriname, a new species has become the primary species, which is Plasmodium vivax. So having Plasmodium vivax as the new primary malaria species means that we need to adapt the Malakit. It needs to be able to differentiate the malaria species, and it also needs to include radical treatment for Plasmodium vivax liver stages. The treatment of Plasmodium falciparum and Plasmodium vivax differs. So this is something that we have to do to make the Malakit more effective. And for this, we would also need to adapt the tools and the recipient training, which is the intake process of the miners. The kit is not just given to the miners, but it is given in the context of a training in which they are given the information on how to use the kit, but also have to show that they know to handle the kit and to be able to use it. So the tools for this need to be adapted to include the vivax adaptations, and also to make sure that the miners understand why it's important to use the correct treatment and to complete the treatment. Also, the treatment in the kit needs to change in that we have to include the radical cure for the vivax liver stages. Currently, the radical cure used in our country is the 14-day treatment by primakine, but globally now a new drug is being introduced. It's called tafenoquine, which replaces the 14-day treatment with a one-dose treatment. So we would really like to move toward the use of tafenoquine as well. To be able to use tafenoquine and pimaquine in the malachites, we need to know the G6PD status of the minors, because people with a deficient G6PD status can have side effects from the use of primaquine or tafenoquine. And in this context, we are working on training the malaria service deliverers in the mining areas to do the G6PD point of care testing in the field, to make sure that the people that we are providing the kits to will not experience side effects because of the inclusion of the radical cure for the Plasmodium vivax liver stages. So within this TDR project, that was a collaborative project with Suriname, French Guyana, and Brazil, we reassessed the tools and messages that are currently provided with the malachites to make sure that we can improve on them to include the radical cure for the vivax, and to make sure that the migrant populations really understand how to use the malachites to their best success. And the second part of the project included the introduction of the point of care G6PD testing in the malaria service delivery network, and to evaluate the capacity of decision making by the malaria service deliverers in determining if a minor would be having side effects or not if they would use the medication. So it's very important that they make the right decision in providing these kits to the communities. And the third activity in the project was to engage in a global discussion about the prevention and control of malaria in mobile and hard-to-reach populations, and exchange experiences about innovative approaches in an international symposium. First, with regard to the reassessment of tools and messages, a social study was conducted to see what was the knowledge of the disease of by the gold miners, causes, symptoms, preventive measures, and treatment, and to try to adapt the tools to upgrade that, and also to bring the message of treatment adherence to antimalarials that needs to be implemented to ensure that we prevent drug resistance development in these mining sites. So the tools were tested in the communities, and we are currently in the process of evaluating the outcomes and working on adaptation of the tools, improving on the messages that have been provided in the malachite. The point of care G6PD testing was introduced in the malaria service deliverers network. The malaria service deliverers were trained, and the implementation was done under supervision of the malaria program. And their capacity to be able to use this test and to make decisions based on the outcome of the test was evaluated. And then there was the international symposium, which was a very successful event with interest from around the world and a lot of participation. The main objective was to share experiences and lessons learned from innovative approaches to malaria control and prevention in mobile and hard-to-reach populations, to also share results from operational research projects or pilot studies, and to discuss the applicability of these strategies in different contexts. And further, we have developed a report of the meeting with an overview of what was presented and the outcome of the discussions. This document will be provided on the website and also disseminated among participants And we hope it will be a basis for guidance development for malaria prevention and control in mobile and migrant populations. More information about this international symposium is available on the website, where you can find the agenda, the posters that were presented, the presentations themselves, and the videos of the symposium. So our next steps include to strengthen community engagement and improve ownership of the interventions among these populations. We are already working on introducing tafenoquine as a radical treatment, as a new radical treatment for 5X malaria. And in the context of a collaboration between between Brazil, French Guyana, and Suriname, there is a new study ongoing that is called the CUREMA project, that really looks at how we can best include and transform the radical cure for 5X among these highly mobile and hard-to-reach population in the Guyana Shield. And then, as a follow-up of the international symposium, we are going to continue international advocacy for these targeted approaches toward these challenges populations. And the first congress that will happen, in which we will again present the topic and hopefully initiate a global discussion, is the International Congress for Tropical Medicine and Malaria in Bangkok in October. So that's already in preparation, and we are very thankful for the support of the WHO and TDR and Swiss GPH for this special session in this Congress in October. Then, how does this affect malaria elimination in Suriname? Well, it is very successful in that now we have also eliminated malaria in the mining sites in Suriname, and we have a very strong surveillance of the imported malaria cases. In 2022, so far we have 0 indigenous malaria cases and only 1 introduced case that was linked to the mobile migrant communities in the mining sites. And so far we've reported 28 imported malaria cases, of which 2 were the falciparum malaria and the majority were 5X malaria. So what are we going to do next? We continue to prevent malaria re-establishment in stable communities, which includes strengthening of the health system. And we would like to continue prevention of malaria re-establishment in mobile communities, continue to study our options towards innovation and adaptation of our strategy to make sure that we really reach these communities and are in fact effective in our approach. And then we would like to continue collaboration with neighboring countries and international stakeholders to elevate the malaria elimination goal to the regional Guyana Shield level and address cross-border malaria transmission. We would like to work with the countries to discuss data sharing, to discuss sharing of best practices, to further develop studies in the fields of diagnostics, surveillance, and entomology. And we would like really to help our neighboring countries and maybe also other countries to present the example that we have here in Suriname with these mobile migrant communities, and discuss the options for challenging populations. So we would like to thank the TDR and other funders for supporting our work, and we hope to be able to continue the collaboration. And with this, I thank you for your attention, and I look forward to your questions.